Thank you very much for the invitation to speak at the symposium. My name is Yohei, and I'm going to talk about rapid diagnosis for bacterial resistance. Here are my disclosures. So what are the goals of rapid diagnosis? Speed in itself is not really the goal of rapid diagnosis, but rather through early diagnosis, we hope to implement appropriate therapy in a timely manner, improve patient outcome, including mortality, length of stay, and quality of life of the patients, prevent emergence of resistance, reduce healthcare costs, and inform infection prevention. There have been several major innovations in diagnostic microbiology, and examples of progress made in the last decade include introduction and deployment of MALDI-TOF MS, increasing uptake of NOD-based syndromic testing, and improvements made in data processing and adoption of artificial intelligence in some areas. But there are also changing environment challenges. We're always facing emerging and re-emerging diseases, as has been exemplified by the COVID-19 pandemic. And that comes with ever-increasing workload, under pressure to contain costs. In terms of external environment, the anti-infective research and development has been relatively stagnant compared with some other fields of medicine. There's been a lot of mergers and acquisitions in the diagnostic industry enterprises, which has led to changes in how we do things. Funding for research in diagnostics has also decreased. And we're facing ever more stringent regulatory requirements. So with that, we'll move on to the actual diagnostics, starting with the turnaround time. So if we look at medicine overall, for instance, ABG results are available in about 1 minute. And it's been that way for at least 20 years, as far as I know. Likewise, CBC and chemistry results are available in 15 to 20 minutes. Even in the field of infectious diseases, if you look at HIV, a rapid testing, a diagnosis for HIV can be made in as little as 20 minutes. But in clinical microbiology, if we look at blood culture, we wait 1 to 3 days till positivity. And then ID and susceptibility testing takes another 1 to 2 days for a total of up to 3 to 5 days. So that's a lot of time to wait for the results. But we also know the importance of rapid diagnostics, especially among patients with the most serious infections. So here's a famous work by Dr. Kumar about 10 years ago now, which reported that an hour delay in effective antimicrobial initiation increased in-hospital mortality of septic shock patients by about 10%. So common sense in clinical microbiology, or what we're used to doing, may not be a common sense in medicine. And there's issue around empiric therapy we do all the times. One is that it's not practiced in other medical disciplines. It's associated with increased toxicity. It can lead to damage to the microbiota, selection of antimicrobial resistant or AMR organisms and genes, increased drug and hospital costs, and empiric therapy can also be a barrier against anti-infective development. So to evaluate new anti-infectives, new molecules should demonstrate higher efficacy than comparators. And new molecules intended to treat AMR infections should really be trialed against AMR infections. But in the big picture, only a portion of infections are AMR infections. And efficacy against non-AMR infections may have limited clinical significance in terms of predicting efficacy for AMR infections. So how can AMR infections be recruited into clinical trials? And one way is to randomize patients, a lot of patients during empiric therapy, but that leads to a big trial size. Alternatively, if we can randomize after the diagnosis of AMR infection is made using rapid diagnostic, that enables smaller trials and smoother path to a development approval of new anti-infectives. So really, rapid diagnostics are important in both clinical practice and in terms of promoting development of new AMR treatments. So turning to identification of and susceptibility testing, the challenges and improvements we can make is in terms of turnaround time for susceptibility testing. And also, I think, exploring possibility for a direct from specimen testing. We now routinely use MALDI-TOF MS for species identification from isolated colonies. It's very rapid, inexpensive, and databases are improving. There have been some gaps, but they are being addressed. So for instance, with non-TB mycobacteria, identification was sometimes difficult, but that's improved with improved pretreatment. And identification of anaerobes has also improved with expansion of the database. So we're interested in, can MALDI-TOF MS also be used to predict resistance? I'll take MRSA as an example. So detection of PSM, phenyl-soluble modulin, can predict MRSA due to its association with the MEK element. It's reportedly highly specific. There has been issues with the sensitivity, but it can be improved to some extent by use of detection of multiple peaks. One limitation is that it only detects certain SCC MEK types that carry the PSM gene. We can use MALDI-TOF to detect colistin resistance as well. This is work I've been pursuing for several years now with my collaborator, Dr. Ernst at the University of Maryland. So we can detect modified lipid A, which actually causes colistin resistance if you have a negative ion mode instrument. Beta-lactam resistance is another big one. However, direct detection of beta-lactamase proteins, enzymes, has not been successful. Rather, resistance to beta-lactams is predicted based on detection of beta-lactam hydrolysis. So an example here would be carbapenemase production, where one can incubate bacteria with imipenem for, say, half an hour, and then detect spectra of the supernatant. And if you detect the hydrolyzed product of imipenem, that indicates the presence of carbapenemase. And this approach has a sensitivity specificity reaching 100%. And this method can be applied to other beta-lactamases mediated resistance. For example, by use of ceftriaxone, it can be used to predict the presence or production of ESBL or AMP-C enzymes. There has also been an attempt to directly predict susceptibility, not resistance, by detection of growth on MALDI-TOF MS. So this is done in a way similar to broth microdilution MIC testing, but you detect spectra after 4 to 6 hours of incubation in antibiotic-containing broth. And this has been applied to bacteria as well as certain fungi. And it's recently been reported that it can be applied to mycobacteria with longer growth periods. And another exciting development is the potential to directly culture bacteria on the MALDI target plate to detect a susceptibility in a much shorter time frame than the conventional MIC testing. MALDI-TOF MS can also be used for outbreak analysis to some extent. Here's an example with Enterobacter cloacae, where spectral analysis clustered outbreak strains at the bottom of this dendrogram, if you can see the screen, which had good concordance with the results of MLST multi-locus sequence typing. And there have been several work published on using this approach. We can also use or detect membrane lipids instead of proteins for a rapid identification and some prediction of resistance. And lipidomics' potential advantages over proteomics, which is the current standard approach to a MALDI-TOF MS in microbiology, is a higher resolution, potential for direct from specimen identification, and concurrent detection of resistance mechanisms. And we know that at least a polymyxin resistance can be simultaneously detected or predicted with species information using this approach. It does require a negative ion mode on the MALDI-TOF MS instrument, which is starting to be marketed for clinical microbiology. So moving on to phenotypic susceptibility prediction, I'll introduce a couple of new approaches, devices. One is accelerated phenosystem, which is already approved and used in the United States. It takes positive blood culture medium and purifies it with electrophoresis, which is followed by species identification by fish fluorescent in situ hybridization, which is done in about 1 hour, and then followed by real-time monitoring of growth by a digital camera, ultimately resulting in MIC reporting in about 7 hours. So this technology significantly reduces a turnaround time. Identification down from 24 hours to 1 hour, and susceptibility testing results from really closer to 50 hours down to 7 hours. But the big question is, with this technology, does early escalation and de-escalation occur? So to test this, an RCT of 500 positive blood cultures has been conducted. The first speaker, Dr. Patel, was instrumental in this trial. And the bottom line was that escalation to appropriate therapy happened sooner, but de-escalation to appropriate therapy not as soon. And no difference in length of stay or mortality was observed. One limitation of this study was that it was performed in areas with relatively low background antimicrobial resistance rates, and results might be different if it's done in places where there's lots of resistant organisms and infections. Moving on to a genotypic resistance prediction. So I'll just highlight one test, which is film array pneumonia panel, which amplifies 33 targets for identification of bacteria, viruses, and also some AMR genes from BAL or mini-BAL in just over an hour. And it has very high concordance rates for both positive cultures and negative cultures. It is certainly expensive. And in terms of susceptibility testing, it only detects AMR genes, presence or absence of those genes. So it requires a conventional culture. So it's really an add-on test, not a replacement at this stage. Now, this one is not quite prediction of resistance, but T2 sepsis is an interesting technology which directly detects pathogens from whole blood, so not positive blood cultures, but from blood itself. It does so by detecting agglomeration of supramagnetic particles induced by DNA amplification by T2 magnetic resonance. And this particular test can detect 5 bacterial species, escape pathogens primarily, with a 4 to 8 hour turnaround time. And it's even more possibly more sensitive than blood cultures, which is, I think, also really interesting. And right now, it only detects species, but in terms of technology, I think it certainly has the potential to be expanded to include antimicrobial resistance genes. At this point, it's very expensive to be used regularly in the clinic, and the clinical impact remains unknown. So by detecting AMR genes, appropriate therapy may be informed early, especially if you, for example, if you have Staph aureus, which is negative for MAC-A, you know that it's MSSA, and modify your treatment accordingly. But resistance can be predicted, but susceptibility cannot always be predicted. For example, the likelihood of a strain being an ESBL producer is low, but not zero, even if no ESBL gene is detected. It could be that a gene was did not happen to be on the panel. So these concerns may delay a de-escalation after all. And it also cannot detect a mutations-based resistance or resistance based on gene expression. So what does it take for rapid diagnostics to succeed? I think MALDI-TOF MS has really presented itself as a prime example. So it's clearly easier and faster than the conventional method. It has low running costs. Species identification is unequivocally important. And it introduced a minimal disruption to the conventional workflow. And most importantly, it replaced, not added, to the conventional method for the identification part. But it doesn't really have to be all high tech. And I'll I like this example, which is a carba-NP for detection of carbapenemase producing Enterobacteriaceae. It uses mixed crude extract and imipenem to detect carbapenemase hydrolysis by imipenem, and acidity changes brought about and subsequent color change in the buffer. It's very easy to do, and it has 1 hour turnaround time from colony to result. And I think we're that a similar method, modified carbapenem inactivation test for CP detection, has now been widely adopted in clinical microbiology worldwide. So in summary, rapid diagnosis of MR informs appropriate therapy and infection prevention. An ideal test should be inexpensive and replace the conventional methods. The benefit of rapid diagnosis on important outcomes depends on the local epidemiology and context and should be evaluated. And finally, low-tech diagnostic tests, rapid tests, can really make a big impact. And with that, I'd like to thank you for your attention.
So thank you very much, Professor Yohei, for your very interesting talk. We have Professor Doi with us right now in his live Q&A. We don't have any questions, so for any one of you who might have questions, please continue to type it into the chat. But perhaps first I could start off with a question, Professor Doi.
Yes.
I was quite intrigued when you produced that CID article showing that escalation increases quite fast, but the de-escalation was not so soon. And we see it a lot in our clinical practice, especially in areas or sections of the hospital in which AMR are more prevalent, for example, in the ICU, as well as, like, say, our transplant units. So providing the antimicrobial resistance profile might be important for more targeted therapy. But a lot of times, do you have any comments on how we could sort of like further improve practices in addition to trying to better communicate, better stewardship to our colleagues?
Yes, I think, yeah, we all face the same question. It's often uncomfortable to de-escalate based on a limited, especially genotypic testing information. And I think it's all contextual. If you have someone who's septic in ICU, I mean, even as a stewardship person, you probably do not want to change the course until we get the conventional testing results available. Whereas if someone is sort of doing well on the floor, there's sort of room, if you will, you might go ahead and advise them to de-escalate at that point. So, we didn't go into the stewardship today, but that's clearly needed. And I think Dr. Patel had a great introduction into how omics might change microbiology, and I think it will. But I also feel that improving or speeding up sort of conventional phenotypic testing is also important. And I think research and development wise, I think they're complementary, and we need to work on both of them.
And maybe just to add on to that, how do you foresee the technology improving further to speed up phenotypic sensitivities?
Yeah, so again, didn't have time to go into time, but there's things like microfluidic device, optic detection of morphological changes in back. I think there's sort of interesting ideas, startups. I don't think none are quite ready to be introduced, but I think we'll have. This is somewhat my personal opinion, but if we know that a test is actually detecting the behavior of the pathogens, as opposed to say like gene was present, absent, or expression was up and down. As clinicians, they might have more confidence, but that's just my take.
Thank you so much for your very useful insight. So I think we come up to the next speaker.